A very warm morning to this August gathering. I hope you're all doing well and precautions to be safe. On the behalf of the Department of Economics and Psychology, St. Xavier's College, Jaipur, I, Kanvika Sharma, along with Meghna Raj Saxena, welcome you all to this webinar on the topic The Cost of COVID Treatment in India, Who Bears the Burden? Organized as a part of the Economics Lecture Series, which is an annual event of the department. COVID 19 has been gravely affecting the world, and the situations become particularly difficult for countries like India, who have a very large population, to be supplied with adequate medical facilities and economic support from the government side. In such a scenario, it becomes very essential to ask questions about the responsibilities being shouldered by the government and the citizens and to analyze who is bearing the burden on a higher scale. So, to shed some light and educate us about these crucial questions related to healthcare economics in India, we have two very prominent speakers amongst us today. We have Professor Indrani Gupta with us, who is Professor and Head, Health Policy Research Unit at the Institute of Economic Growth, New Delhi. Health Policy Research Unit, set up by MAM in 1998, is the first of its kind in India. It remains among the few places in the country that conducts policy oriented research on the health sector using tools of economic analysis. MAM holds a PhD in economics from the University of Maryland, College Park, USA, and a master's in economics from the University of Delhi. Professor Gupta's work experience includes teaching and positions at some very renowned academic institutes, the World Bank, and the Government of India. Her areas of interest cover a wide range of topics in the area of health economics and policy, including demand for health and healthcare, health insurance and financing, poverty and health, costing and cost effectiveness, economics of diseases, and international agreements. MAM has a wide range of research papers, reports, and books to her credit. We welcome you, ma'am, and we are honored to have you amongst us. I would now like to invite Meghna to introduce our second speaker for the day, Dr. Saktivel Salvaraj. Over to you, Meghna.
It's a pleasure to have amongst us Dr. Saktival Salvaraj. Sir currently holds the position of Director Health Economics, Financing and Policy at the Public Health Foundation of India, New Delhi. He is engaged in research, teaching, and advocacy in the area of health systems, healthcare financing. He was a postdoctoral fellow at Harvard School of Public Health, US, and has a PhD in health economics from Jawaharlal Nehru University, New Delhi. Sir has contributed significantly to the development of high-level expert group report on universal health coverage. Also, he contributed immensely to the development of state health policy of Uttar Pradesh. Earlier, he was engaged as a health economist in the National Commission on Macroeconomics and Health, Ministry of Health and Family Welfare, New Delhi. He was also the founder secretary of Indian Health Economics Association. Apart from this, Sir contributes regularly about health policy developments in national dailies. Also, he has to credit several reports involving evidence generation and policy creation at the national and state level. We welcome you, sir, and we are honored by your presence.
Generation and policy direction at the national and state level. We welcome you, sir.
Welcome you, sir and ma'am. So, without any delay, we will begin the discussion. Before I invite our first speaker to take the virtual stage, I would like to inform the participants that if you have any questions for our speakers, you can type them and drop them in the chat box. We will take them up in the question and answer session after the discussion. So, with this, I invite our first speaker for the afternoon, Professor Indrani Gupta, to enlighten us about how prepared our health sector is for such pandemics and what should be the roadmap to improvise upon it. So, over to you, ma'am. You're welcome.
Thank you very much. And thank you, the faculty, Dr. Bula, especially for inviting me. It's always a pleasure to talk to students. So I'm happy to be here virtually. Since we are talking to, I'm giving this lecture for students of your college, I thought we'll just go very broadly with a broad brush, discuss the pandemic and in the context of the health sector of the country, to see whether we were prepared or we were not prepared or we were halfway prepared, and what we could have done differently. I guess I have about half an hour, so I just keep a tab on the time so that I don't eat into Dr. Saktivel's time. Now, so the way I thought I will structure my presentation was basically talk a little bit about COVID-19. Everybody, all of us are living through it, so I don't have to say much there. Why we think that we should have anticipated the likelihood of rapid spread, what would have been the impact on the vulnerable, how prepared is the health sector, some of the health system control knobs, health financing very briefly because it's an integral part of the preparedness, but Dr. Saktivel is going to talk much more about it, I believe, and then looking forward. Now, we now know that we are basically topping the total number of absolute cases. We have been vying for that spot with the USA, followed by some other countries, Brazil, Russia, Argentina. Of course, the total cases and the new cases per million still lower. The total cases are very high, but the new cases per million would still be lower than many other countries. In the beginning, if all of you recall, tests were very slow to pick up, and we were not getting enough tests done. But over the last 4 or 5 months, the tests have been gradually and suddenly also ramped up heavily. So we are doing many more tests, but I'll show you a graph which will tell you whether we're doing enough even now. A much higher caseload, especially post-lockdown. In fact, it'll be interesting for, all of you are in Jaipur, but in Delhi we have kind of a surfeit of cases, and I'm in an institute campus, and there are about 15 cases already, where we had none. So we know that the cases are increasing. Whether they are showing up in statistics, that is a different question. But we all believe, many of us believe, that the statistics do not really indicate the total birth on the country of COVID cases. And many cases are going undetected in and there has been a significant fatigue with the COVID onslaught we've had in our, which is amazing. Should have anticipated that we would have an onslaught of cases much earlier on. Now, if you look at COVID-19 tests per 1,000 over August and October, because data is available differently from for different countries, these are some of the high burden countries. And you can see that, about 4 months ago is actually not doing as many tests as it could have. So the total tests per 1,000 are pretty low at 66, whereas US, Russia, Spain, Chile, etc., they've done many more tests. So more the tests done as transmission. Community transmission is when you can't trace from where you got the infection. Broadly, that is the way you can define it. Even now, the government of India denies that there has been large-scale community transmission. They say it is now there in some pockets, but there has been no large-scale transmission. Delhi government has been saying, however, that Delhi is already in community transmission. Now, this kind of controversy that we are not in community transmission does not help, because if you deny that you're in community transmission, then your policies would be, adjusted differently. But if you do know that you're in community transmission, you will do much more than you are doing. Now, why should we have anticipated that there would have been a lot of transmission, a rapid transmission? That is one reason for as anticipating this, which we should have done in March and April as well, is the presence of infectious diseases in the country. And if you look at the latest national sample survey round, the 75th round, as you know, the NSS has these specific rounds, and there's a health round that it does every 5 years or so. So the latest round is for 2017 and 18, which gives outpatient data and inpatient data, that is hospitalization and OPD. And you can look at the share of disease groups in OPD and IPD in the NSS 75th round. If you look here, you can see that the big blue pie slice is basically for infections, both for OPD and for IPD. So India is still grappling with infectious diseases. That still continues to be the major source of our disease burden. At least in treatment-seeking behavior, that is what it shows up, and it will also show up in other data. Now, who are actually getting affected from these communicable and non-communicable diseases? So in the bottom two bars are for communicable diseases, right? And the x-axis shows you the share of age groups in the total. So the OPD bar shows that 0 to 14 has about 42% share, followed by the adults, and then 60 plus. So if you look at this, one thing strikes you is that for both in non-communicable and communicable, but especially the focus right now is on communicable diseases, the adults are the most susceptible to communicable diseases, not the elderly, the adults, and of course the children, because the reasons would be pretty much the same. So the transition, when you come to transmission, while the entry of COVID into the country can be traced to international travel right there, before January, February, etc. Once in, there was always a fairly non-negligible probability that the infection would have spread to others through community transmission, through rapid transmission. That is why is that? Because the modes of transmission for COVID are going to be fairly similar to other infectious diseases. Lack of social distancing, lack of hygiene and sanitation, congested habitat, lack of awareness, etc. So those are the same reasons. So whether it is a normal flu or COVID, the modes are always the same. And the infections are going to spread mostly through adults, because the previous chart just shows that adults take a big chunk of that. And it can also spread actually to children, but because of school shutdown, etc., this time the COVID thing did not impact on kids that much. But adults would have been the fair game to assume that they would spread the disease. But while the adults are supposedly the most robust groups in terms of resilience to disease because of their age, because the age is on their side, it is also a deadlier infection than many the world has encountered. And there is increasing evidence that comorbidities in both adults and the elderly, like hypertension, diabetes, chronic obstructive pulmonary disease, COPD, CVD, these comprise major risk factors for patients with COVID, both adults and the elderly. And the data does indicate that adults with all these seek OPD and IPD care in non-negligible proportions, in pretty high proportions. In fact, a relatively higher proportion of the elderly with any of these conditions seek OPD care. This is clear from this particular table. If you look at this table again from the NSS 75th round, you will see who seeks OPD care and who seeks IPD care. These are some of the comorbidities that are often talked about in the context of COVID. Diabetes, cardiovascular disease or CVD, hypertension, asthma, any above 4 conditions, or any NCD, that is any non-communicable disease. The age groups that you're seeing, 15 to 59, 60 and above for both IPD and OPD. Now, if you go down if you see that, you can see that the elderly have many more of these comorbidities compared to the adults. Adults means 15 to 59. So any 4 conditions, if you talk about 60% in OPD are elderly and about 34% in IPD are elderly compared to 30 and 7. So clearly, the elderly are very vulnerable once they get the infection, the transmitted from adults or wherever they get it from. And if you look at the demand, that who will be impacted the most during the epidemic, that also is very clear that before COVID, this is before COVID data, obviously. So if you look at OPD and IPD and look at the age categories as you go down the left column, you will see that your demand increases with increases in age. This is demand because you're actually seeking care. We are not talking exactly of total number of people who are sick. We're just saying that the demand for treatment for OPD and IPD goes up with increases in age. So what that really implies is that there is, and obviously there's morbidity underlying this, and these people must be sick, that's why they're seeking care. So the case, we always knew that the elderly were very vulnerable. Our data always told us that the elderly would be very vulnerable. Not only do they have many comorbidities, they also are the people with other illnesses without outside of communicable, non-communicable diseases. And that is why they end up seeking more care than the young and the adults. Much, much higher proportion of care-seeking behavior from the elderly. So who will be impacted the most? Yes, the adults and the elderly. All the infection will spread mostly through adults in the beginning. Of course, then it can spread from each other, and that's exactly what community transmission is. So it may have started with the adults, and any disruption to the healthcare system is likely to disproportionately impact on elderly treatment because they are the people who are seeking the most care. And if you have a static total care scenario of supply, then the care will be squeezed out for this particular group in the absence of adequate hospital and other services, or in the absence of an elastic care scenario. Adults will also be impacted in significant numbers, though less than the elderly. And you have to have high preparedness of the health sector for all of this. Now, how do you prepare the health system for a pandemic? Now, pandemics are basically a serious threat to economies and livelihoods, and therefore it's imperative to understand how one should prepare for it. Now, if you have a resilient health system defined as the capacity of all actors, institutions, etc., to prepare and effectively respond to crisis, maintain your core function when a crisis hits, and be informed and be ready to change course if you so think that you need to do that. Now, you need a resilient public health system for fighting pandemics like COVID, infectious diseases and outbreaks, pandemics, epidemics, you name it, you need to fight all those things. You need a strong surveillance system to catch where the infections are. So your surveillance system has to be very strong. You need adequate health personnel to deal with the infections. You need sufficient medical supplies and equipment. So you need all the gloves and the syringes and the ventilators and all of that. And you need continuous training of all your personnel. So those are the basic ingredients of a resilient public health system. Now, who would do all this? Pandemic prevention and management is basically a public good, and your economic students, as you understand, that the market is unlikely to provide prevention and management of pandemics. So it is mainly the government. The onus falls on the government, which has to put in place a resilient health system to manage outbreaks and epidemics. And health systems, according to WHO, if you look at WHO's definition, it's very neat. It comprises 6 building blocks: health financing, which Dr. Saktivel is going to talk much more about, human resources, medicines and technologies, health information, health service delivery, and also governance, so how well you govern the health sector. So these are the basic things that you need to fight a pandemic. Now, what evidence have you seen of India being prepared? Now, unfortunately, there's not much out there, but there was a joint external evaluation that WHO had initiated, and India was part of this, but India has never compiled its report. Its report is not available on site, on the website, unlike many other countries' reports. So that kind of tells you that maybe we are not so serious about it. There has been a recent exercise in terms of ranking 188 countries in epidemic preparedness, and India is not doing very well. one is most prepared, and India gets a score of 3. So it shows that, our preparedness has, even external evaluation doesn't show a very good preparedness. So coming back to some of those 6 building blocks. So suppose you take physicians, nurses, hospital beds, and in the last column, we'll talk very briefly about health spending. But basically, these are the countries that have been hard hit. And you see how many physicians per 1,000 they have, how many nurses per 1,000 they have, how many hospital beds per 1,000 they have. And if you go down the list, India is at the bottom, not only because I've put it there, but also it is at the bottom because it's really one of the lowest compared to all these other countries that dealt with a very bad burden of epidemic. So countries that had good health indicators like physicians and nurses, adequate numbers, even they were so hard hit. So a country that is not already does not have a good indicator on any of this. It is no surprise that we were struggling to meet the demand. Even our hospital beds were inadequate. Our physicians have been much less. Nurses have been less. Technicians have been very low, etc. And I'll return to the health spending part a little later. Now, this is from the government's own rural health statistics, 2018-19, which shows a shortfall in health personnel. And I just thought that it's important to look at some of these numbers. So these shows, what PHC is, right? Primary health center, community health center, etc. So these are some, if you look at the rural health statistics, you'll get a lot more. But I just thought I'll put up some here. So basically, you can see the shortages. So physicians in CHC, 87% short. Pediatricians, short. Surgeons, short. Ops gynae, short, right? Lab technicians, much, thankfully in CHC they're there, but in PHC they're very short. So overall, the picture of health personnel that you get from government's own statistics is of huge shortages everywhere in the country. Mostly in the EAG states, the Empowered Action Group states that were called Bimaru states earlier, as you all know. There you will see much worse statistics, but on an average, this is what you see. So there are significant shortfalls in personnel and in both rural and urban areas, sometimes to the tune of 80 to 85% in some categories. There are shortfalls in infrastructure as well, the buildings. So personnel is one thing, but do you have those structures where you need to go? In rural areas, sub-centers and health and wellness centers are 23% short on an average, PHCs, etc., 28% short, CHCs are 37% short. So shortages everywhere. And urban health system is actually pretty dismal. A lot of people work on urban health system and help. I don't want to get into too much of discussion, but it is really, sometimes it's much worse than the rural health, personnel and infrastructure. Now, when there are shortages like this in the government sector, so these are shortages in the government sector, right? So you're basically saying that since the government has to move into action when there is a pandemic, let's look at the government structure. So government, we know that there are shortages of infrastructure and staff. So no doubt that the demand will be met in the private sector. And we do have a very vibrant private sector, which is mostly unregulated. We have let the private sector just grow and grow and grow without regulation. So when you have this kind of scenario, what is it that you see from the NSS? This is again NSS data. Ailment last 15 days, you can say this is like the OPD, and then hospitalization, IPD. Where do people go? The first column is public facilities, second private, and third is charitable trusts and NGOs, etc. So from this table, it's very easy to see that people go to private sector for their treatment, whether it's OPD or whether it's IPD. OPD, they go much more to the private sector actually than they go for hospitalization, but overall people are going to private sector to seek care because government sector is missing in action. There are other estimates that show that there is a shortage of beds in the government hospital even without the additional COVID burden. In fact, we have also done some of that. And this shortage is being met by private facilities with concomitant burden of out-of-pocket expenditure, right? Because when you seek care in private facilities, you are going to spend much more out of pocket. And this diagram actually shows you out-of-pocket medical expenditure per hospitalization by type of hospital. So if you go to the first three bars in rural area, the blue is government and the orange is private. So this is the differential in out-of-pocket expenditure. So when you seek care, when a person seeks care, they would spend 42,000, about 43,000 in government, hospitalization, and 27,000 or more in private sector. And that is the case also in urban areas. So the shortages of beds, shortages of equipment, shortages of everything in government sector has ended up giving us a scenario where people are going to private sector and getting hit by high costs. There has been a very recent study as well on the number of hospital ICU beds and ventilators, that is post-COVID study. And they also show that the distribution of beds and ventilators in India are uneven, mostly concentrated in 7 states. So the question is, how prepared were we? So since we were very slow to increase testing, and in the earlier, why were we slow to increase testing? Because we were not prepared. We didn't have kits. We didn't have the detergents, all that you need for testing were not there. And you wonder why. We also saw in the early stages acute shortages of PPE and other essential medical supplies, including ventilators, oxygen concentrators, etc. All those things were also very, very short in the initial stages. And we got a lot of cases of health workers getting infected due to lack of these gears. And even one death is too many as far as I'm concerned. If the deaths are because we are not prepared, I think that's a very, very bad thing to have happened. So we did lose health workers because we were not prepared in the early stages of the pandemic. We had almost zero capacity for producing the PPEs, and I didn't know much about this PPE thing, but I was reading up and I was struck by the fact that we had no capacity to produce PPE. We had very limited ventilators. Of course, we picked up speed from, I think, June, July onwards. But why could we not produce our own domestic medical supplies? The medical device industry, where you get all these machines and equipments from, these depend on imports to the extent of almost 80% of its requirements. And I again wondered, I have not worked on medical device industry, maybe Shakti can throw some light, but I could not quite understand why we were not better equipped to produce our own medical equipments and supplies. Why did we have to depend on imports so much? So in even May and June, we were reading that we are getting it from China, we are getting it from UAE, but why? So in that melee, in that jhamela, we kind of lost time, we lost people, and we had high morbidities, and we were completely struck with this whole thing in a very bad way. So the other thing that happened is, because of shortages of personnel, infrastructure, equipment, etc., the pandemic has squeezed out non-COVID care as well. Because, we have, before COVID, we already knew of this acute shortages going to private sector, etc. But during COVID, most of the government facilities were gearing up to deal with the pandemic. So what happened was that must have happened. See, data is not there yet. What must have happened is that non-COVID care was getting squeezed out. Now, of course, many people postponed non-COVID care due to lockdown, said, okay, chilo, baad mein karwa lenge, not now and all that. But others who had to go to care, and I know many people, I have gone, many of my family members have gone for care because, you have a dental thing or you have something, you have to go. So many would have preferred to go to private providers because A, they're available, they're accessible, and they seem less risky. And anyway, the others are not there. So again, the result, you would have seen an increase in out-of-pocket spending, more possibly than your NSS is showing right now. So if you do another survey, maybe you will get better data and we can verify whether out-of-pocket spending has gone of my discussion. So why did all this happen? Why did India remain so unprepared to face a pandemic? And we've had many have happened. Every time there is a chance to do things differently. Why did our health sector not respond better? And to me, it seems, and many people would agree, I guess, that we've never prioritized the health sector. We have not prioritized the health sector because the health sector was crying out for a number of reforms, which we never undertook. Now, one key ingredient remains health financing because, even to run a household, you need a household budget. So run the health sector, you need the health finances. If you need to fill in the gaps of equipment and personnel and infrastructure, you need financing to get all this. So financing would remain a major control knob. However, health financing is a necessary, not a sufficient condition for building a resilient health sector, because you can throw good money after bad. If you're not careful with the meager money that you have, you're possibly going to be basically wasting that money. So there is a governance thing that comes in. So suppose this is just a very quick foray into the invisible or the intangible thing called governance. So suppose you plot your IMR, infant mortality rate, on the y-axis, and you plot the per capita health expenditure of countries, of states on the x-axis, and you draw a line, let's say, on the 2000 mark. So 2000 mark has Kerala and Maharashtra and Tripura and some other states. Basically, what we're saying is, for the same money, different states are being able to get different outcomes in terms of IMR. So that does show some preparedness, or that just shows something like governance that may be going on in the background. We knew Kerala had responded very firmly in the beginning. It has slipped since then because of very festive seasons or whatever. But I'm confident that despite the huge numbers in Kerala, you will see less economic impact, because Kerala's health system is more resilient at the end of it. This infection may have spread very fast, but I'm hoping that they will be able to minimize the costs because they have a better health system than many others in the states. So I'm just going to end, because I had a lot more on the financing part, but I didn't want to give Shakti's thing away. I just want to say that one key control knob of health financing has remained static over the years in the country. It has not moved from 2000 to 2017-18, which is the actual figures. Let's not look at the revised and budget estimates. You can see basically we have spent the same amount out of GDP on health. That means we have not really prioritized health. What do other countries spend? Well, the world spends about 6%. Middle income countries spend about 2.8. Upper middle income spends 3.3. Thailand spends 2.9. Sri Lanka spends 1.6. India and least developed countries, and we are no longer a least developed country, we spend about a percentage of our GDP on the health sector. So this result of the continuous low investment has resulted in our being dependent on the out-of-pocket spending. So in terms of total spending, 63% of our expenditure are financed by out-of-pocket. And also remember that most people do not have health coverage, that is health insurance. So we are in the group of countries that finances its health spending through private and not public funds, not a good thing at all. And also remember that we have a federal structure. The states bear the major brunt of health spending, right? So sadly, less than 70% of our total spending is incurred by the state government. So the onus of responding to the pandemic is also on the states, but the states need money. And the states have also not been spending money at all. I mean, there is a lot of literature on that as well. Did we see a huge increase in the budget recently on health? No, we have not. And I'm not going to spend a lot of time on this. We have seen marginal increases in nominal terms, which will disappear if you take it in real terms. So over the years, we don't seem to be at all prioritizing health. So it's not a surprise that health sector has so many gaps and it was not prepared for the pandemic. We can only hope that in times to come, this is going to change, and this pandemic would have taught India a lesson in terms of how we can prioritize our health sector in the coming years. So I'll just stop here, and I'm already running a bit late. So thank you very much for listening. Over.
Thank you so much, ma'am, for this very educating talk. India definitely needs a resilient public healthcare system and needs to step up its production and preparedness for the health infrastructure as compared to many other countries in the world. When the government claims of shouldering the responsibility in an efficient manner, it definitely needs to make sure that it has sufficient medical infrastructure and supplies to cater to needs of such a huge population, not only during a pandemic, but even in the normal conditions. For a nation like ours, where we value our human resource so much, it's a very important asset to us. We really need to work on a more efficient healthcare system through a prioritized budget. So thank you so much, ma'am, for educating us all about how India needs to step up its game. Now, I would like to welcome Dr. Saktivel Salvaraj, to further educate us on the issue under consideration, focusing a little more on the financing aspect. So we welcome you, sir. Please take over the virtual stage.
Ma'am, please stop presenting the screen. Yeah.
I've stopped.
Yes, ma'am. It's gone now. Thank you, ma'am.
I have access to present it. It's present now.
Yes, sir.
All right. All right. I guess this is visible to everyone.
Yes, sir. It's very much visible.
I'm audible as well.
Yes, sir. You're perfectly audible.
All right. Absolutely. Thank you. Well, I think it's a pleasure and honor to deliver this lecture on COVID-19 and its impact. At the outset, I just wanted to thank Dr. Bola Chaudhary and then the organizers for inviting me to share some of my thoughts and then the emerging evidence around COVID and its impact. So what I really intend to do in the next about 25 minutes is to share some of the emerging evidence. First, I'll briefly talk about the macroeconomic implications of COVID-19, and then largely talk about the financing aspect, followed by the macroeconomic implications. Okay, so given that Dr. Indrani Gupta has already set the stage in terms of discussing how prepared India is in terms of against the pandemic, that really sets the perfect stage for discussing some of the major implications of COVID-19. Well, uh, to begin with, I think, so as you all know, India's current COVID numbers are only next to US with about 76 lakhs cases today as of today, and a death of about 1.23 lakhs as of today. So from barely a few cases in March 2020, India enforced, I think, one of the stringent and the longest ever lockdown, shutting down airspaces, workplaces, schools, interstate movement of people, and so on and so forth. And the results are very clear before us. The lockdown-driven result is very clear before us. India's growth is likely to contract by negative 10% during the current fiscal year. And this is certainly unprecedented, no doubt, a global meltdown driven by the COVID pandemic. It's unprecedented in the history of the world and in India too. So as you can see, India's growth rate, which used to hover around 8% or so during the last decade, has begun to falter, not this year, but since 2016, but has in fact taken a severe beating this year. Now, the slowdown was already happening due to monetization, GST-related issues, and so on and so forth. And now, and one of the stringent and the longest lockdown ever, India's growth story is in actual shambles. Although I must put some caveat saying that October figures has certainly shown some robust growth with uptick in GST collections, revival in sales, manufacturing and construction activities, no doubt, partly due to pent-up demand, which is rising gradually, and also spending associated with the festivities. But having said that, the COVID pandemic has driven a lot of job losses, and it is also a lot of emerging evidence shows that the poverty has indeed gone up. Having said that, although the October figures are robust in the Indian scenario currently, however, the crisis, I think, is far from over. And in fact, the long-term impact of one of the longest and the stringent lockdown is likely to linger for a long time to come. And some of the concerns related to employment that you see here, where you can see, and of course, poverty and income inequality is also going to increase. As you can see very clearly, the unemployment rate went down sharply, and then as a result, the labor force participation rate reduced sharply during the lockdown period, although it has shown a little bit of increase in recent couple of months. Another set of evidence that's emerging globally as well as in the Indian scenario is the issue around poverty, which is in fact, the evidence very clearly shows that the poverty reduction has actually suffered its worst setback in decades after almost nearly a quarter century of steady global decline in extreme poverty. In fact, the new set of evidence from the World Bank 2020 report also shows that the new poor are emerging who are more urban, better educated, and less likely to work in agriculture than those living in extreme poverty before COVID-19. The results also shows that the pandemic is actually deepening income inequality, and India is a classic case for this deepening in income inequality, which threatens the inclusive economic recovery and future growth. As you can see, in terms of poverty, if you look at the global poverty as well as in the Indian scenario, you would see that in a steady state scenario, you would have expected the global poverty to go down from the last year of 8.54 to about 7.5% this year, and 8% and 7.5% next year. But that was in a steady state. But given the fact that the COVID status globally as well as in the Indian scenario, you can see that the poverty levels are going to actually go up. In fact, it's going to go up to the levels of what was seen in 2016 and 2017. So that's a major concern for just not only the global level, but for India as well, because a large part of the global poverty is basically, you can see that most of the poverty levels are situated in the Indian context, where about 300 already, this is before COVID-19 situation, where there are about 300 million people below the poverty line. And you would expect after COVID, you would expect that numbers to go up substantially. So that's in terms of the macroeconomic conditions and then the impact of COVID-19. But from there, let's move on to the financing aspect. The point that Dr. Indrani talked about earlier is important. Now let's recollect the fact, and also let me restate some of the facts that what she has suggested. India is perhaps one of the most, I would say, the most privatized healthcare market in the world. Why do I say that? For two reasons. India is extremely privatized market for two reasons. One, if you look at the delivery of healthcare services, both in terms of delivery of healthcare services and as well as in terms of the financing, India is considered to be one of the most privatized healthcare market in the world. In terms of delivery of healthcare, you would notice that about 70% of all the outpatient care visits happens in the private sector, and about more than half of all the inpatient care, that's hospitalization care, happens in the private sector. So essentially, if you look at the delivery of healthcare services, largely private dominated in nature. As far as the health financing is concerned, it's again, India is one of the most highly privatized healthcare financing market in the world. Why do I say that? For the simple reason that India currently spends about close to about 4% of its GDP on healthcare. 4% of GDP on healthcare, which comes from, so the funding comes from different players, including the government, which includes state and central government, and largely from the households out-of-pocket payment, and then the private sector spending. Now, if you put all of them together, so that comes to about 4% of GDP on healthcare. So if you look at the distribution of the 4% of GDP on healthcare, about 1/3 of that spending comes from the government, both central and states put together, and then a large part of it, almost 2/3, other spending comes from the households. So that's about 62-63% of the entire healthcare spending in India comes from the households. If you look at the government spending, the ratio between center and states is about 1:2. So in a sense that, if you look at the per capita basis, on a per capita basis, government spending, both center and states put together, is about 1,500 rupees per capita. So 1/3 of that comes from the center, and about 2/3 comes from the states. Now, if you look at the graph up there, I can say that 2/3 essentially states' own spending from its own resources that's collected from tax and non-tax revenue. And the rest, 1/3, comes from the center. A part of it is used by the center itself, but a large part of the center's spending on healthcare goes through via the centrally sponsored scheme. There are two major centrally sponsored schemes that you're all familiar with. One is the National Health Mission, which is the largest component, and then the rest, the second centrally sponsored scheme relates to the PMJ. So if you put together these two, that's the transfer from the center to the states. So in a sense, what we're really looking at is that the public spending is just about, in terms of GDP, it's about 1%. Now look at the states. Now, states are important for the simple reason that the healthcare delivery actually happens at the state level. Now, if you look at the state's spending pattern, it's interesting to know that on an average per capita spending, government spending on healthcare is about 1,500, as you can see down below. On an average, that's the latest estimates. But of course, this 1,500 is also marked by the fact that the huge variation between different states. States such as Delhi, Kerala, Uttarakhand, the smaller states, Delhi, Uttarakhand, Kerala, some of the northeastern states, Jammu and Kashmir, Assam, they all. So if you look at their spending, the per capita spending is a little higher than the larger states. But if you look at the health spending, government health spending as a percentage of the total revenue expenditure, it's interesting to see that's on an average, India's spending, government health spending as a percentage of total revenue expenditure is about close to about 6.5%. But having said that, there's a huge variation between different states. Interesting point to remember and note is the fact that Delhi spends one of the highest amount in terms of total revenue expenditure. That's about 16%. I mean, way above all the other states. In fact, almost 10 percentage point than the all India figure. So the point that I'm trying to make is both center and states share, but the larger share of the financial burden comes from the states, almost 2/3. But within the states, there are huge variation in terms of spending patterns. I mean, that's the point that I wanted to drive home here. Now, if I move further, if you look at the relationship between the per capita GST, that's basically the income per capita, as you can see on the horizontal axis. And then the vertical axis, it's represented by per capita government health expenditure. You can see a clear correlation as per capita income of the states goes up. You can see that the per capita government health expenditure also accelerates. So you can see a very clear correlation there. Things like, so if you look on the left-hand side down below, Bihar, Uttar Pradesh, Jharkhand, whose per capita income is about in the range of about 50 to 70,000 rupees per capita, against, let's say, Haryana, Uttarakhand, Kerala, and Gujarat. So that's about 4 times more than Bihar, Uttar Pradesh per capita income. So similarly, as you can see, as the income goes up, you can see that the per capita government health expenditure goes up as well, from about 400 to 500 by Bihar and Uttar Pradesh to as high as about 1,800 to 2,000 by Kerala, Uttarakhand, and other states. And then if I were to extend that logic and then look at the relationship between per capita government expenditure and then the per capita government health expenditure. Again, there is a very clear correlation between the government health expenditure, which is related to the per capita general government expenditure. So if you look at Bihar, Uttar Pradesh, on an average, their per capita general government expenditure is about 15,000 thousand rupees per capita, against Uttarakhand, let's say smaller states like Kerala, Uttarakhand. So that's about almost twice or thrice than the low per capita income general government expenditure spent at Bihar and Uttar Pradesh. So clearly there is a correlation between the GSTP as well as per capita general government expenditure. As it increases, you would expect the government expenditure, health expenditure to go up. But having said that, I just wanted to go back to what I said earlier, the fact that although India spends about 4% of its GDP, if you look at the distribution of that spending, a lot of that, in fact, two-thirds of that spending comes from the households. As you can see on the left-hand side, the total health expenditure of that, that's about 4,980, that's about 5,000 billion rupees. Out of that, about two-thirds, that's about $3,150 billion goes for households out-of-pocket payment, which are not actually pooled in a sense. So in health financing, it's often said that if you have a better prepayment and risk pooling, the chances, the probability of household spending on healthcare is lesser and lesser. That's what, as you can see, but even within the risk pooled, prepaid and risk pooled funds, you can see that the public subsidies, so that's basically the government spending, whether it is through the NHM route or the PMJ route, is one of the largest component, which are non-contributory in nature. Remember, these contributions come from the taxes and non-tax revenues of the government. But if you leave that out, some of the other pooled funds is also contributory in nature, whether you talk about ESIS, CGHS, and other private employers. But that component is still lower in the Indian context. So that's the point to remember. So essentially what we're saying is financial burden is extremely high on the households. This is a point that I've already spoken earlier, and Dr. Indrani also talked about the fact that whether you talk about outpatient care or inpatient treatment, it's largely driven by the private facilities. So if you look at a different set of households, whether you talk about self-employed, salary earners, or even casual workers, the choice appears to be private facilities. Remember, almost three-fourths of the entire outpatient treatment actually happens in the private facilities. And about more than half of all the hospitalization cases actually happens in the private facilities. So that's something of a major worry. The reason why I wanted to draw your attention to this is the fact that if you go back to look at some of the emerging evidence in terms of the prices charged in different states across for COVID costs. So it's interesting that although there is a huge variation, two or three things are very striking from this particular table, where in terms of the cost of COVID care treatment in isolation bed and ICU without ventilator and with ventilator, the cost of expenses for a household ranges anywhere between 60,000 to about 1.5 lakh, and for treatment in ICU without ventilator. And for treatment in ICU with ventilator, it can range anywhere between 90,000 to about 2.5 lakh. So, but think of the fact that for an average Indian, almost 80% of average Indian, the average income is monthly spend of average income is just less than anywhere between 6,000 to 25,000. So it's almost an impossible task. In fact, extremely impossible for any of these, 80% of the families to go to any of the private facilities and get treatment, access and treatment. Absolutely impossible task. So what would really happen is, I'm sure the evidence and then the survey that might be done in future would throw up a lot of information, evidence about how vulnerable people were made because of the pandemic. In fact, our own estimates before the pandemic, based on the 2017-18 the survey, NSS survey, suggests that there are about 55-60 million people who are pushed below poverty. They're impoverished because they have to pay from their own pocket. Now, the COVID would have impoverished them much more. In fact, it would have even brought in more and more people into the impoverishment net. And that's a point that I wanted to drive home. But this is just about cost of treatment in a hospital setting. Now, with and without, there are costs to the patients and to the government. Now, I just wanted to draw your attention to the fact that if you look at the households out-of-pocket payment, a larger part of the households out-of-pocket payment actually goes into buying medicines. Almost 2/3 of the entire households out-of-pocket payment goes into buying medicines. Now look at COVID drugs treatment. One of the drug which is often seems to be popular, one of the antiviral drugs which seems to be very popular among the government, among the doctors, the remdesivir. Now, there is an antiviral drug which may be considered in patients with moderate or severe conditions, and also those who are on oxygen support. Now, there are about 5 companies producing and supplying it with a price range anywhere between 4,000 to 5,500 rupees per vial. Now, you need 6 vials of for 5-day treatment, which would cost about 30,000 per patient. Now, think of the fact that, now go back and remember our monthly income of 80% of our families are just anywhere between 6,000 to 25,000. Now, how do you expect any households to even seek treatment with remdesivir? This is just you're paying only for the medicines. Now, it's interesting to see that Gilead Sciences, which basically has licenses for the remdesivir, has entered into a voluntary license with about 5 Indian companies. And interestingly, they're all supplying at different prices, anywhere between 4,000 to 5,500. But having said that, in June, July, and August, we've seen not one but several newspaper items which suggested that the remdesivir and another antiviral drug called the favipiravir, they were sold at astronomical prices. We're not talking about 4,000 and 5,000. In fact, in the black market, it was being sold at anywhere between in the range of 30,000 to 60,000 per vial. Now think of the fact that if somebody has to have 6 vials for a 5-day treatment, so that's you're talking about 2.5-3 lakhs, right? So that's the kind of situation that households are pushed into. Now, unfortunately, COVID drugs doesn't have, whether you talk about remdesivir or favipiravir, they're not brought under price capping. There's no price control on those drugs. Unfortunately, the government can step in and do a price capping, but unfortunately, it just didn't do. Number 2, India still can use the global TRIPS flexibilities, the trade-related intellectual property rights flexibilities, by allowing by giving compulsory licensing to the Indian manufacturers, and then marketing at a lowest price. But that's just not happening. Neither price capping happening nor compulsory licensing being issued to the Indian companies to produce those drugs at a cheaper rate. But having said that, now let's also remember the fact that remdesivir, which is now the popular drug, as I said, has still got only restricted emergency use. In fact, it doesn't have a full marketing go ahead. So what does it really mean? Restricted approval means it means that the patient has to provide informed consent before treatment is initiated once it's been prescribed by a doctor. So in fact, a recent study also shows that remdesivir just doesn't have any comparative benefit. So that's about the treatment aspect. Now let's look at the vaccination. Now a lot of things have been talked about universal vaccination of COVID-19 vaccines. Let's look at the financial implications of vaccinating the entire population. For many of you who are may or may not be aware of the fact that there are several vaccine candidates globally, close to about 100 plus in the development phase. Interestingly, what we really see in globally is the vaccine nationalism, which is under test. What is vaccine nationalism? It is likely to lead to some countries being able to vaccinate their entire population, in fact, the wealthy ones, while those in many low and middle income countries will be denied access to COVID vaccines. Interestingly, you must have heard about the fact that Russia and China already have one vaccine and have already administered them among its army personnel. If you look at the global practices, there is something called the advanced marketing commitments, which are being secured by countries through investment of large amounts of public funds, which are being used for R&D of COVID vaccines. Using that, because remember, if countries are able to negotiate, remember, just monopsony power, one purchaser. Using that purchasing power, they can procure large volume with a lower price. So they can strike a huge, large-scale deals, which is what is currently happening. Now, globally, there's something called COVAX. This is a global effort to provide equitable access to vaccines. But the question is, will COVAX be able to achieve its aim? Now, that's a question that we have. So what happens when there's going to be a vaccine? Now, priority will be given to those who are at high risk and who have comorbid conditions, and also among those with high mortality rates. Now, that would include security personnel, health workers, elderly population, children, and young population. Now, in terms of financial implications, it's interesting to know that India, of course, has used its manufacturing capability to pre-order about 600 million doses of COVID vaccines. And as per today's reports, it's also negotiating for another 1 billion doses, which is enough to vaccinate almost half of the population, if not the entire population. But remember that first, if you have a vaccine administered, you need additional booster dose. So essentially what you need is 2 doses per person. So what would that really means is that assuming that the 2 doses would cost about $10, so that's about 750 rupees. But remember, the current government annual health expenditure is about 1,500 per capita. So let's go back. Now, what this would really mean is that the government would need about 80,000 crore just to vaccinate the entire population. Remember, this 80,000 crore is only for buying vaccines. It doesn't talk about, it doesn't include the amount of money needed for setting up supply chain, if there is new supply chains are required, and then administering the vaccination program. So, so the government itself would require about 80,000 crore. Now, the reason why I put this up is interesting to note that if you go back to the central government, for instance, the central government has very clearly articulated the need to vaccinate the entire population, number one. And it also said that it would put the it would take the financial burden and end up spending. Now, it's interesting to see that can this be done in 1 year? So that's the point that I'm wanting to drive home. If you go back to the current year's budget, central government budget is about 66,000 crore. So just vaccinating COVID cases, the entire population, is going to be more than the current budget, central government budget. So we're talking about 80,000 crore, right? And if you were to include the other expenses associated with administering and delivering vaccines, so you're looking at about 100,000 crore. So with just about 66,000 crores being spent currently this year for the entire health care by the central government, so the point is, will this be possible at all to vaccinate the entire population? So I think that's the point that's there before our policymakers. Let me try and wrap up by articulating my ideas about what needs to be done. So clearly, as you can see, the evidence is before us. India is, of course, health has never been the priority. If you look at the last 70 years of post-independence phenomenon, only if you leave out the mid-80s, where the public spending went up to about 1.5% of GDP, but other than that, public spending has been either at 1% or less than 1% of GDP. So there is a clear need to accelerate public spending from the current levels of 1.5% to about 2.5%. In fact, if you look at the 2018 National Health Policy, it very clearly articulates the need for accelerating public spending from the current 1% to 2.5% by 2025. But to reach there in 5 years' time, if you look at the last 5 years of spending, we are nowhere near. So I think, and the COVID has actually triggered, and there is a need certainly for accelerating that spending from the current levels. If we do that, both the central and states have to bear the burden. But having said that, let me also qualify the fact that if you look at the state's financial position, they're very precarious. In fact, you must have heard about the fact that almost daily states have been going to the center asking for more money. Even their own genuine GST compensation that they are not getting from the center. So that's states in a very precarious situation. It's going to be extremely hard for states to manage the entire. If the COVID-19 were to persist for a longer time period, it's going to be disastrous for many states fiscally. So that's the point. But having said that, if this were to happen, if public spending were to be accelerated and then twice, it certainly would be one of the best things to happen in India, and it is likely to reduce financial burden on households significantly. Two other things that needs to be done is we currently have capping of prices for COVID treatment, but the problem is implementing them. Implementing them in letter and spirit, that's really not happening. We have state after state announcing capping of COVID treatment prices, but nothing much is done to implement them. And sitting in Delhi, we can, daily, almost every day we see in newspapers the complaints about private sector players not implementing the capped COVID prices in letter and spirit. So that's more important. The other point that I also wanted to bring home, which I've spoken earlier, is capping of medicine prices is also critical. In a pandemic, if you don't act, we have something called the DPCO, the Drug Price Control Orders. Currently, about 364 drugs are being price capped. That's only about 10%, 15% of the entire medicine sold in the country. So I'm not sure what stops the government from capping some of the important COVID-19 related medicines. This is absolutely essential, extremely critical at this stage. But having said that, let me also stop by emphasizing the fact that we need to ramp up vaccine delivery system in a big way. And then, of course, there is a need to scale up public spending on vaccine procurement, which is more critical now than ever. But not only on COVID, but also on other vaccine procurement and delivery. Because currently, if you look at the non-COVID, I mean, you're talking about the universal vaccines. I'm not talking about the COVID vaccines. The current coverage is only about less than 70% across the country. So there is a need to strengthen that system, because if you're talking about primary care, strengthening primary care, vaccine plays an important role. I think I'll stop there. Thanks. I'll be happy to take more questions and answers. Thank you.
Thank you so much, sir, for helping us better understand the topic. So you emphasized on how India is being one of the prioritized sector in healthcare, where 70% of outcare visits happen in private sector. How India spends 4% of GDP on health, where 1/3 comes from the government, central government, and while 2/3 comes from the state government. You also talked about two important missions, National Health Mission and PMG, how it helped India to increase the healthcare in India, how the funding comes from state and different state, how different states spend on this healthcare, where Bihar, say for example, Bihar, Jharkhand, UP spends around 50,000-80,000, which is 4 times less than states like Gujarat. So you also talked about how universal vaccinations need to be nationalized. Basically, the meaning of this, I happen to understand, is where some countries is able to give vaccines to the large population, while less developed countries will be denied access. How India has used its maximum capability to pre-order 600 million vaccines. So your main focus was on how public spending should be increased, how the government should financially fund it, and how the prices of medicines should be critical. Keeping of prices of medicines should be critical now. All right, sir. So this was truly a thought-provoking session. Now we have the question and answer session. If the participants have any question, they can type in the chat box. Meanwhile, I'll go with the first question. All right. So your first question is from Aditya. So how can we recover employment which is lost during period of COVID-19?
Can we take a couple of questions and then I can respond together?
Okay, sir. All right, sir.
Few questions.
All right, sir. So Aditya has questioned you, how can we recover employment which is lost during period of COVID-19? And in the current scenario, how local markets are crashed and online e-commerce market giant firms settled abroad like Amazon and Google are making huge profits. What strategy government have for the emerging monopolies of e-commerce giants? So, ma'am, another question is for you from Rishabh Somani. He says, it seems that even though the number of infections have gone through the roof in the past few months, the leniency of people and the authorities' control and prevention measures has only grown. Do you think that the government authorities are to be blamed for this or not? What would have been a better approach when the cases started to spike? Also, ma'am, there's a question for you from Kanvika. When India has educational institution set up for the education and training of medical practitioners, then why do we face a shortage of the medical staff? If we need a higher number of them, should our government consider increasing its medical education and training spending as well?
Can we answer some of the questions that start?
Yes, sir. Yes, sir. Sure.
Two quick points one about the employment recovery. How do we ensure that the employment recovers back to the pre-COVID levels? So I think in my view, there are two or three things that needs to be done quickly. One is reviving the MSME sector, which I think the government is trying to revive the small and medium scale, small and medium scale sectors by giving them incentives and then maybe large scale investment in them. That's one thing which is important. Remember the fact that a lot of the casual laborers and then the um, uh, most of these laborers who left during just before or immediately after the COVID, and we need to make sure that they come back so that MSME sectors are revived back to COVID-19 levels, pre-COVID-19 levels. The other two things is has to be demand driven. Unfortunately, most of our stimulus package that we have seen in the last about 6-7 months, they're largely supply driven in nature. They're not demand driven. The real problem lies in demand. People just simply don't have money. That's a fact of life. So either you do by ramping up the social security net, number one, or simply do a income transfer, simple income transfer. If America and many European countries can simply transfer money, just simple transfer of money to people, let them buy things, and that's the way you can accelerate the economic growth as well. So one is the income transfer to the at least 70-80% of the population uh, who are both impoverished as well as vulnerable. They may not be poor, but vulnerable. That's who are above poverty line, but economically vulnerable. So income transfer, I think, is extremely important at this stage. In addition to spending more and more on social security net, I think that's the only way to ramp up the economic recovery. To the other question of e-commerce, so there are 2 points there. One is the fact that we need to allow the e-commerce to prosper because from the point of view of consumers, it's certainly a win-win situation, number one. But having said that, when it comes to the issue around anti-competitive practices, so that's extremely important. Unfortunately, India has allowed capitalism to flourish, but without good anti-competitive. Although we have Competition Commission of India, which has competition law, but unfortunately, most of these competition laws are not really being used to stimulate the big things like e-commerce to flourish in such a big way. So there is, of course, a need for Competition Commission of India to step in and do something about the larger players. This is happening across the world, in Europe as well as in US. If not, at least in Europe, a lot of things are happening. But in US, there's a huge lot of talk, especially during the election time. There's a lot of talk about big e-commerce players having large pie in the sales. So there are, of course, laws, but the point is how do you make them work? So how do you make markets work? Markets won't take care of themselves. We'll have to make the market work, and that's where we need not only laws but also how do we make them work? That's important. I think those are 2 questions. Are there any other questions?
Yes, sir. I'll read the further questions, and meanwhile, you and Indrani ma'am can decide who has to answer that as per the subject. So I would request ma'am to please turn on her camera as well if it is possible. So I would read the next question, which is from Rishabh Somani. It seems that even though the number of infections has gone through the roof in the past few months, the leniency of people and the authorities regarding controlling and prevention measures has only grown. Do you think that the authorities or the government are to be blamed for this or not? What would have been a better approach when the cases started to spike?
Okay, so I have three questions, or maybe two and one and a half. Shakti can also answer. He's a health person. So I think there was one question on medical education and
Yes,
why
ma'am.
don't we have enough doctors? Uh, we are just not investing enough in medical education, as simple as that. There are so few seats in reputed medical colleges. And there is medical education and there is quality medical education. So when you don't have enough seats in government medical colleges that have
We are having
Ma'am, I believe there is some network glitch on your end because we are not very much able to hear you.
Hello?
Yes, ma'am, now you're audible.
Yeah, now I'm on. So basically, I think that the medical education investment also comes from this 1% GDP, remember? So anything that you take, it's under investment, including medical education. So that's my answer. And yes, it has to be ramped up heavily. There was another question on, and I think the first and the last questions are really related. Do you think that government authorities are to blame, etc.? Look, it's a pandemic. Nobody was prepared for it. So blaming anyone is not the right approach. But to be complacent and say that we have done what we could is also not correct. Uh, of course, we are all responsible people, and if we give up mask, social distancing and wearing masks, etc., it's also our fault completely. And I think that most of us are, many people are to blame for spreading the infection. At the same time, the lockdown that happened was too draconian. It was too sudden, and did not really achieve what it was supposed to achieve because it happened at the wrong time. I mean, when the infection started coming in from international travel, at that point we could have done a lot more by way of shutting down airports, etc. Because at that point it was in our control. So there have been, different steps taken that have not helped us, and not being prepared in by way of the health system preparedness has also been partly the government's fault, not in real time fault, but over the years kind of fault of neglect. So. Finally, if you ask me, is the government not doing enough? The answer is no. It is trying its best, but it is working under constraints that it created for itself. So it's really not anybody's fault that it doesn't have funds, it doesn't have the wherewithal to deal with the pandemic. At this point, with opening up and lockdowns being removed, there is hardly much that the government can do. Maybe it can just steeply fine people without masks and all that, but there is really not much that it can do. It is now free for all, and survival of the fittest, literally. I think the surveillance has a lot to, be said for. I mean, I think we don't really have a great surveillance. We're missing cases. We are still not ramping up testing as much as we could. There are in some states testing rates have fallen. So I think we can't let up our guards and let down our guards and relax and say, okay, we've done our bit. So we have to be vigilant, and the government can play a huge role in that.
Thank you, ma'am.
yeah. Can I come in? There are two things that I want to talk. One is about the lack of medical personnel. I think we need to put this in a context. The larger context is lack of medical personnel has to do with two or three things. One, we need to talk about, understand, are we producing enough? So that's about production and about the distribution. and then the migration of medical personnel. These are three important points. Are we producing enough? Maybe yes, and maybe not. A large part of it is produced in the private sector, and lesser to some extent in the government sector. But the problem is the distribution and then the migration, out migration that happens. A lot of these skilled people go out of the country, and we lose most of them, number one. Number two, in terms of distribution within the country, if you look at the distribution, a lot of these skilled personnel, medical personnel, are concentrated in the urban areas, mostly in metropolitan, other tier 1, tier 2 cities, and less so in the rural areas. So that's the major part of the problem in terms of lack of medical personnel, number one. The other point which we need to understand is that are we talking only, so the moment we talk about medical personnel, our only attention is only doctors and specialists. We fail to understand that there are major players who can contribute much more, such as nurses and then ashas and others. For instance, in the last about 15 years, ashas have contributed enormously, but with little incentive, number one. Number two, now look at the doctors. Now, most of the private players attract them, the specialists, and then pay a large sum of amount of money. But look at the doctors who are languishing in the public sector with hardly any incentive. They work 12 hours, 24 hours a day, and yet get hardly get any recognition. Number one. And look at the contribution of nurses. In fact, studies after studies, not just in India, but across the world, have shown that a lot of simple procedures and interventions can be done by nurses. You don't need doctors in many of these places. So I think we need to really have a different strategy in terms of medical personnel. I think, in my view, I think we need to look at Sri Lanka and many other countries where they've done much better with less number of medical specialists. That's a point. It's an important point. I think we shouldn't really lose sight on this, number one. As far as the other point, the point about the question about leniency, is the government lenient? Maybe yes and not really. But I think one of the major problems that the both central and state government are not doing enough is about testing. Since we are not doing testing enough, the number of cases that we're getting is also less than, number one. The second point is, Delhi is a very classic case where both RT-PCR tests are happening. In fact, antigen tests are much more than RT-PCR tests. So the moment not just in Delhi, but many states, the moment you have antigen tests, number of antigen tests have gone up, the positivity rate has actually came down. So I think there is a need to ramp up RT-PCR tests and rather than relying more and more on antigen tests. If you do that, I think we'll be able to test more people and track them. The third point that I wanted to emphasize is the fact that the tracing mechanism that we had, Kerala, of course, had an interesting, excellent, significant tracing mechanism. I think we simply lost track of the tracing. But I also recognize the fact that tracing becomes absolutely impossible when there is community transmission. Yeah.
All right, sir. Thank you so much for answering the question so well. So we will take, I think we have time to take one or two questions more. So we have one question from Ms. Purvi Miratwal. She's a faculty member. She's asked why Italy had so high mortality rate even when their healthcare system was one of the best worldwide.
Okay, that's. Can I answer? Oh, sorry.
Yes, sir. Sure. Sure. Please go ahead.
Okay, the simple answer is just not only Italy, Spain, most of Europe. Why is that death rate is much more than in many of these South Asia or even African countries? For the simple fact that, look, the answer lies in demography. Right? If you look at the demography, most of European countries, especially Italy, Spain, UK, you name them. If you look at the demography, the share of population, elderly population, is much higher, almost double or triple than the Indian average. The fact that India has the advantage still in terms of demography is the fact that we still have a lot of young population. Even if we have more people infected, but our death rate is lower simply because of the demographic factor.
Yeah, and also in many of these countries, you know, the elderly, the care homes saw huge death rates. And populations got wiped out almost in many of the care homes. So as Shakti is saying, it's really the elderly that took the hit, and they comprise most of the deaths.
And the comorbid conditions, along with you have elderly population, you would expect comorbid condition. So in fact, Lancet called it as a syndemic. So what syndemic really means is that you have infectious disease in the name of COVID, but actually affecting those with NCD conditions. So infection turning into NCD conditions. That's called syndemic.
All right. Thank you, Suran ma'am. So we'll take this one last question, which is from Aditya. He is asking that the Indian economy is hurling towards a recession, the first in over 4 decades. The COVID-19 outbreak is likely to force a real GDP contraction of between 5 to 10%, depending on the estimates you're following. So with this contraction will come a host of unsavory consequences, weaker revenue and higher expenditure for the government, lower earnings and spending for the consumers, and a surge in defaults for financial institutions. So from where will the government, or where will we be able to finance this? From deficit finance or from collateral debt? That's the question, sir.
I mean, I'm going to talk about the central government because state simply doesn't have the kind of bandwidth to do much on this. So the government has to invest and spend more. So where would the money come from? There are two ways in which money can be mopped up. One, of course, you can borrow domestically. The government certainly can borrow domestically, number one. Not only borrow for itself, but also borrow and then give it to the states. Even at the expense of increasing the fiscal deficit, I think we shouldn't really be worried about fiscal deficit going up. If even Western countries are not really worried about fiscal deficit going up, we should certainly not be worried so much because this is not a steady state we are in. We are in a pandemic. In a century, almost a centuries, if you look at the growth rate, India has never had a negative growth rate of about 10%. So this is the time to act and
Could you do us a please?
Another option is what stops the government from printing? What stops the government from printing? It can print money. And so the point is the central government has all the bandwidth. It can print money, borrow money, and then give it to states. Because states where all the actions and activities happen. And that's the only way to drive the demand. In fact, demand is such a low level. Even before the COVID situation, pre-COVID levels, the demand was extremely low because of demonetization and GST. And COVID has actually brought this even further down, the demand levels. So I think there is a need to accelerate demand at this stage much more significantly at a faster rate.
Yeah, I mean, I just want to back up that thing. I mean, a lot of macroeconomists have been saying that, you know, we often think that money creation is inflationary, but those are under normal circumstances. At this point, money creation is actually going to be, I mean, of course, the macroeconomists are divided on that. But right now, given the situation, putting money in the hands of consumers is what you need. And this inflationary thing that you think of will play itself out once the demand recovers. So that's one thing. The other point I want to make, Shakti has mentioned all the really important points. We should not worry about deficits. We should not worry about all of that. We should borrow, etc. Is that government can also cut down on many of the unnecessary expenses it's right now incurring on a variety of things. When your economy has gone for a toss like this, there are things that you don't have to do, but we are doing it. And I don't want to sound on this side or that side of the political this thing, but there are unnecessary expenditures that we are undertaking that were not needed at this point, and I can cite many, including something that really bothers me in living in Delhi, is that do we really need to alter the vista of Delhi? For instance, you know that the new parliament is going to be created, an old I mean, why do we need to do all that? Why do we need 2 helicopters, 2 planes to fly? So there are things that we really need to focus on. I think that there is politics that's going to be played here, and there will be some of that. And I am very strong in this view that somehow suddenly economists are no longer seen as very interesting or useful creatures. You can't find many discussions around economists anymore on television or any other place except a few channels. That never used to be the case a while ago. About 3-4 years ago, you had lots of discussions around the economy, lots of discussion on unemployment. None of that is happening except in a couple of channels. So I think the hawa kahin aur ja rahi hai. So we are in for trouble, frankly speaking. If you don't value economists, it is going to be a really tough time ahead. Sorry for that very pessimistic view.
Thank you, ma'am and sir. Definitely, we need these pessimistic views to bring the government agencies online and to make them understand that there is a problem and we need to address it in front of the nation. So, thank you, ma'am and sir. I hope all the participants must have got answers to their questions. So, I would request Meghna to take on the proceedings from here.
Thank you, Kanvika. So, the roots of all goodness lie in the soil of appreciation of goodness. And to express our appreciation and gratitude, I invite Head of Department of Economics and Psychology, Ms. Purvi Nedepal, to deliver the word of thanks. Over to you, Purvi, ma'am.
Thank you, Meghna. Honorable speakers, Professor Indrani Gupta and Dr. Sakti, and my colleagues and all the participants. It's my privilege to propose a vote of thanks on this occasion. I, on behalf of the Economics Society and the Department of Economics, extend a very hearty vote of thanks to our esteemed resource persons who so well explained the economics of health during this pandemic and cleared all our queries regarding the same in such an enlightening manner. I must mention our deep sense of appreciation for Professor Indrani Gupta and Dr. Shakti for giving their precious time and sharing their knowledge with us. I'm extremely thankful to our principal, Reverend Father Rex Angelo, for providing encouragement and support. Thank you, Father. I also extend my gratitude to Father Worky, Father Raymond, and Father Sherry for their constant support in all our endeavors we pursue. And this program is a collective effort of many hands. So I extend my big thanks to Dr. Bula Chaudhary and the Economic Society and other faculty members and students of the department for their continuous support. Thank you all for making this event successful with your contribution. And last but not least, I am thankful to all the participants. Without you, this event wouldn't have been a success. Thank you, one and all.
Well, thank you everyone for organizing this webinar, and I think it's been a wonderful session.
Yes.
You can go ahead and share the PowerPoint with anyone who wants it. I'll send the PowerPoint to you. Thank you.
Thank you very much. My pleasure.
Thank you, ma'am. Thank you, sir.
Bye.
Bye. Thank you, Meghna, and thank you, Kanvika.
Thank you, ma'am. Thank you. Thank you, Indrani, ma'am. Thank you, Saktivel, sir, for being there with us. It was an honor to listen to you. And You really helped us learn a lot more about things which we are not able to learn with our everyday studies. These were really out of context for us, and it was a great time to hear to you. And I would also like to thank the management for allowing us to conduct this session, all the teachers for supporting us, and all the participants for being with us today. And we hope that we get to hear and the participants, we hope that we expect you in future events as well, organized by the department. So thank you, everyone. Thank you for being
Thank
here.
you. Bye-bye.
Okay. Bye, ma'am.
Also, a big thanks to all the participants who have joined us now. We hope you got the answers to most of your questions, and we look forward to your presence in many more sessions to come. Thank you. Till then, stay safe and stay happy.
Yeah,
Thank
stay
you.
safe.
Bye.
Bye.